Next, we want to invite up Dr. Parawan to discuss paravisceral transaortic endarterectomy, a case series at a Quaternary care center. I just had to do one of these the other day, so hopefully you're going to give me some tips and teach me some things to know.
Sorry. I may take this. Just kidding.
All right. I apologize beforehand because I've lost my voice, so I'm going to be pretty close to the microphone. All right. I would like to thank the Society for this opportunity to present our work today. I have no disclosures. Atherosclerotic disease of the abdominal aorta typically affects the infrarenal aorta and its bifurcation. Paravisceral aortic atherosclerosis is less common, but it typically affects the orifices of the visceral renal branches, jeopardizing the blood flow to these vital organs. The term coral reef aorta was first coined by the UCSF group in 1984 and is very rare. It describes a heavily calcified exophytic mass arising in the paravisceral aorta, causing severe luminal obstruction of both the aorta and the visceral renal branches. Transaortic endarterectomy, also known as trapdoor endarterectomy, was first described by Stoney and Wiley at UCSF in the 1970s via left thoracoabdominal incision through the 8th intercostal space. Their group published the largest series in the literature in 1991 with excellent and durable results. Since then, only a few centers have published their experience. In 2002, Brigham and Women's presented 14 patients, and more recently, University of Alabama with 5 patients and WashU with 14 patients. The evolution of endovascular technologies has made open operations on the paravisceral aorta increasingly uncommon. Using CPT codes, we identified 16 patients between the years 2006 and 2025 who had undergone paravisceral transaortic endarterectomy. For preoperative eval, we performed CTA thin cuts of chest, abdomen, and pelvis with runoff. And we selectively used cardiac stress testing and PFTs for assessment of the cardiopulmonary reserve. Majority of our patients were white race and female sex with a mean age of 65 years. And hypertension, hyperlipidemia, and active smoking were present in over half of our cohort. All patients were approached through a left flank thoracoabdominal retroperitoneal incision in the 19th intercostal space denoted by the upper marked line on the left. For reference sake, the lower marked line represents the 11th intercostal space, which is typically used for standard open AAA repair. The patient is placed on a beanbag in a modified right lateral decubitus position. And on the right side, you can see that we approach the aorta in the retroperitoneal plane anterior to the left kidney, which is left in its normal anatomical position. The peritoneal sac and its contents are retracted to the patient's right, and this is necessary in order to be able to expose up to 10 centimeters of the SMA. If you go behind the left kidney, this view is blocked by the left renal artery and the kidney. Over here, I don't know if you can see it, but this picture basically shows that we have divided the left cruise of the diaphragm, and this is needed because we want to be able to expose the supraceliac aorta and the celiac artery. Next, another important thing here is that you want to manage your lumbar arteries and you want to control them because once you open up the aorta, this can cause significant amount of back bleeding. And then this is followed by meticulous dissection of the SMA, and you want to make sure you ligate all the lymphatic tissue because you don't want to have a post-op chi leak. And finally, the distal end of the aortotomy that you perform is at the level of the left renal vein. So you want to be able to mobilize that left renal vein by dividing all of its branches, which includes the left gonadal vein, the lumbar, and the adrenal. Following heparinization and clamping of the proximal and distal aorta, as well as the branches, we make a curvilinear aortotomy in order to visualize the orifices of these vessels. The picture on the right has a white dotted line which demonstrates our planned aortotomy. The endarterectomy is initiated with a spatula, and it's important to make sure that you're in the right plane. It looks reddish tan. And the plaque typically shows you which way to go because you want to make sure it's not full thickness, because you may thin out the aorta and you won't be able to repair it primarily. Here you can see that reddish tan surface. The infrarenal cuff is either endarterectomized fully, or in some cases you may need to put distal tack in sutures. A complete endarterectomy of the paravisceral aorta is visualized here, and it is important that you have good endpoints in the visceral orifices as well. The aorta is primarily repaired in a running fashion with a fluoroproline with a small needle. Once flow is restored, we perform an intraoperative completion duplex using a hockey stick probe to ensure you have adequate endpoints. In this picture, the endpoints were adequate. However, just distal to the SMA, just distal to the SMA endpoint, there was a significant amount of disease, which required additional separate SMA endarterectomy. And then, as the arrows point out, these are the typical areas that we examined during our intraoperative completion duplex. I have not pointed out the right renal. We try to visualize it, but this is very hard to look at it using a duplex. Again, with the left kidney down, you have access to the SMA up to 10 centimeters and beyond the orifice. And if you need more length, you can go through the peritoneal cavity and flip the colon towards you. All of this separate SMA endarterectomies are closed with a patch. Here's a final plaque specimen with a separate SMA endarterectomy, removing a total of 8 centimeters of plaque in the SMA. Looking at our data, a separate SMA endarterectomy was performed in half of the patients and celiac in almost 1/3. One patient required a celiac bypass because the origin of the celiac got very thin after the endarterectomy. Majority had a supraceliac clamp placed proximally with a mean clamp of 35 minutes. Completion duplex was performed in 6 patients, with 4 of these requiring additional separate endarterectomies of the endpoints based on the duplex findings. Our 30-day mortality was 0, but during the post-op course, almost 1/3 suffered respiratory and kidney issues. 2 patients required take back to the OR because of a retroperitoneal bleed and a right groin lymph leak. Over half of our cohort were discharged home. One patient had recurrence of symptoms at 6 months and was found to have patch thrombosis of her SMA endarterectomy, and this was thought to be due to neointimal hyperplasia. And this was managed endovascularly with a stent. Another patient had a recurrent disease at the proximal SMA at 9 months. This was also managed with stenting. One patient who underwent this procedure for renovascular disease ended up on dialysis 3 years after her procedure, but this was thought due to the progression of her intrinsic disease. Mean follow-up was 37 months, and 12 out of 16 patients are alive and well without any recurrent symptoms. Here is a follow-up CT scan of one of our patients demonstrating patency of the paravisceral aorta at 4 years. I want to summarize some key points. Proper patient selection is key. Aside from symptomatology and physiological status, you want to make sure they're a good open candidate, and there are some anatomical criteria. Ideal patient is discrete, patients with discrete osteostenosis of the visceral renal vessels with post-stenotic dilation. This is a sign of disease-free artery beyond the plaque. And you want to avoid full-thickness calcific disease of the aorta because the aorta can fall apart. And again, 19 intercostal space through the thoraco-retroperitoneal approach. You want to expose the aorta anterior to the left kidney, and you want to dissect out the SMA meticulously and control your lymphatics to avoid a lymph leak, chi leak, and you can expose up to 10 centimeters. It's important to control your lumbars and make sure you have good endpoints. Transaortic thromboendarterectomy is a good option for select patients with symptomatic atherosclerotic disease of the paravisceral aorta. Our patients had moderate morbidity with durable results. This is a valuable tool in the vascular surgeon's armamentarium. Thank you.
While Dr. Rajani comes up for questions, I want to I want to ask a little bit about how you control the lymphatics. So I think people have different ways of doing this. A lot of people tie them off. I'm a big fan of using ligature back there a lot of times, and I don't think people do that very often. How do you do that?
We tie them off.
Okay.
Yeah, we like it.
Yeah. Just ting ting.
I mean, there's a lot of tying,
Ting ting.
a lot of fellow tying.
Great talk, and well presented, and congratulations on great results. So 19 years, and as you mentioned, it's obviously a lot of endovascular advances in that era, but I believe, like it sounds like you do, this is a disease process that does lend itself well to open surgical reconstruction. So have you noticed a change over that 19-year period? Are most of the cases in the first 3 years, and now it's rare that you get one? Do you see that patients are getting treated endovascularly? Are the patients you're seeing now any different than they were 20 years ago?
I think that we are a little bit more selective in who we choose. We want to make sure they're, from a physiological standpoint, they can tolerate it. Yeah, we are more earlier in the series we didn't use completion duplex. Now we are using it way more. So yeah. Thank you for the questions.
Great presentation. Beautiful exposures from the group in Detroit. My question's about the duplex. So what criteria are you using to chase something? Kind of like carotid duplex, you see all the wispy fibers and you're like, well, what do I go after this, that? So is it just gross anatomy, or is it velocity changes? And what duplex criteria are we using?
That's a great point. We look at velocity. We do look at, you want to make sure you don't have a raised distal endpoint, which is one of the biggest things. Yeah, like for example, in the picture that I showed you, there was the distal endpoint was beautiful, but you go a little bit beyond it, there was a significant amount of disease, and we didn't want to come back and think, So
yeah, it's a lot to chase after doing that, and then having to do an error by fem after that.
We'll finish with one last question.
Hi, I'm Ali Rana from New Mexico. A couple of questions. First, congratulations. Excellent operations. Your clamp time was 35 minutes, and the mean operative time was like over 8 hours.
Yeah.
Is it something specific that takes that long? Like, is it the exposure, or is it the post-op hemostasis, or like post-clamp hemostasis? And then my second question is, in our experience, when we have to do visceral endarterectomies, majority of them we have to do like I will close the aorta and then do an aorta bifem for distal occlusive disease. And your couple of cases that you showed did have significant disease there. So how many were actually done with an aorta bifem?
So 5 patients were done with. Thank you for your questions. They're great questions. A few things that will prolong the surgery is in case you have to do a separate endarterectomy on your visceral vessels, and doing the completion duplex. This adds some time, and again, hemostasis, like you mentioned, and significantly something that prolongs the surgery is, does the patient need an aorta bifem?
Great, thank you very much.